Hello, my name is Bolaños. My topic is Cabozantinib versus Everolimus in Advanced Renal-cell carcinoma. Definition: renal cell carcinoma is the most common form of kidney cancer, with more than 330,000 case diagnoses and more than 114,000 deaths attributed to it worldwide every year. Approximately one-third of patients present with a metastatic disease and diagnosis, and in about one-third of treatment patients with a located disease, the disease will relate. Application in medicine. Cabozantinib is an oral small molecular tyrosine kinase inhibitor that targets vascular endothelial growth factor receptor, as well as MET and AXO-H, of which has been implicated in the pathobiology in metastatic renal cell carcinoma or in the development of resistance to the antiangiogenic drugs exist.
We have conducted a phase 3 trial looking at a novel agent called Cabozantinib, which is a dual VEGF receptor MET and XL inhibitor in a population of patients that progress on prior VEGF inhibitors. The control arm was Everolimus in this trial, which is a drug approved many years ago and been a standard in advanced RCC patients, second line and later. And the choice for Cabozantinib is based on the fact that it does block the VEGF receptor as a backbone, but also block multiple other tyrosine kinases involved in mechanism of resistance, acquired resistance to VEGF inhibitors such as MET and XL. And the study in terms of primary endpoint was MET, showing a hazard ratio of 0.58 and a significant decrease and significant increase in the progression-free survival with Cabozantinib compared to Everolimus. This was already published in 2015 in the New England Journal of Medicine and presented at ESMO. What we did here with the new research that followed is we updated overall survival. These are the final results for overall survival. Overall survival was a secondary, not a primary endpoint on METEOR trial, but it was powered, and it was a very important secondary endpoint, a gold standard in oncology, if you may think about it, overall survival. And actually, overall survival was met with almost 5 months prolongation with Cabozantinib over Everolimus in survival. Response rate also were updated in the presentation and favored largely Cabozantinib. So we have a drug that actually prolong overall survival and also shows superior progression-free survival and response rate over a previously considered the standard drug in Everolimus. What I would add is that the safety profile overall was not different from other TKIs we're used to, although the dose reduction with Cabozantinib were higher than with patients treated with Everolimus. And folks have to be managing well the patient to keep them on treatment as much as possible without completely dropping. It's an art that we have tried to do well as much as possible with now 10 years experience with VEGF tyrosine kinase inhibitor and other tyrosine kinase inhibitor in renal cell carcinoma.
And just to clarify, this was for carcinoma patients who have been pre-treated?
Correct. So these were patients that progressed at least on one line of therapy. Despite that, the trial enrolled also patients that progressed on 2 or more lines of therapy. There were no actually, there wasn't any limit on the number of prior therapy as long as patients were exposed to one or more lines of therapy. In untreated patient, actually, there is a trial, a smaller trial, a randomized phase 2, that is a collaboration between the Alliance, the Cooperative Group Alliance in the United States, and CTAP, that we, had a press release only in May last month, showed also Cabozantinib did improve progression-free survival, which was the primary endpoint of that trial called Cabozantinib, over a standard first-line therapy being sunitinib. However, this hasn't been presented yet, but will be at a later meeting. So it's possible that Cabozantinib, based on the strong biologic background and rationale, becomes not just a second-line or later treatment, but potentially a first-line treatment. And this is exciting times for kidney cancer, exciting times for kidney cancer patients. We are making improvements.
Could you just tell us a bit more about the team who are working on this trial? Because it seems like they've come from all over the world.
Correct. Meteor was an international clinical trial sponsored by Exelixis, was the sponsor, but it accrued all over the world. There was patients accrued in the United States, Canada, in Europe, and in multiple other countries. So it's an international collaboration. There will be abstracts presented at some point looking at different patterns and response and activity according to countries and areas. That is also one of the things that are planned, and we would look at the geographic variation, both in baseline characteristic as well as in activity on this trial.
Pros and cons. Median progressive-free survival was 7.4 months with a Cabozantinib and 3.8 months with a Everolimus. The rate of progressive or death was 42% lower with a Cabozantinib than with Everolimus. The object's response rates was 21% with a Cabozantinib and 5% with a Everolimus. And planned interim analysis showed the overall survival was longer with a Cabozantinib than with a Everolimus. Issue played in Ecuador. Worldwide renal cell cancer corresponds to an incidence of 2.4% in both sexes, a mortality of 1.7%, and its prevalence at 5 years is 2.8%. Renal cell cancer accounts for 3 or 5% of neoplasias in adults. In Ecuador, according to data from the National Institute of Statistics and Census, renal cancer is more frequent in men with 2.5% and in women with a 0.9%. This disease is the most common type of kidney cancer in adults and occurs months after men between the ages of 50 and 70. The age cause is not known.
The treatment of renal cell carcinoma has changed considerably in the past several years. When we think back to the initiation of therapy, we had TKI therapy as the mainstay with sunitinib, pazopanib, and after that there were several other TKIs you could use afterwards. Really the sequencing was unclear and pro-inhibition TKI. Then we had the pivotal Meteor trial and Checkmate 2.5 done at the same time, showing that both cabozantinib and nivolumab offered us improvement in overall survival in the second-line setting. And so that led to a pattern of care where patients would start with a TKI, go on to receive cabozantinib, and then nivolumab, or vice versa. They would go on TKI, nivolumab, and then cabozantinib. And now, as we look at things evolving, the role of immunotherapy is really moved to the front line with nivolumab, ipilimumab approved in the United States, front line for those with intermediate poor risk disease. And we've just heard data on the combination of axitinib and Everolimus showing marked improvement in response rates, PFS, with a press release for pembrolizumab showing improvement in overall survival in the frontline setting compared to sunitinib. So clearly immunotherapy is moving into the front line. And so one of the dilemmas we face is with cabozantinib being studied in VEGF refractory, does prior immunotherapy really, does it affect the activity of cabozantinib? And so that's unlikely to be studied prospectively. We did a retrospective review between ourselves and Emory of 86 patients who had received immunotherapy as the most recent line of therapy and then went on to receive cabozantinib. And what we showed overall is that the activity of cabozantinib was preserved. So by investigator-assessed response, 36% of patients achieved a partial response, with 79% deriving clinical benefit, either stable disease or partial response, with a median time to treatment failure of over 6 months. So I think there's a lot of subgroup analysis that we've discussed in detail on our poster. I think the main takeaway is that in the setting of prior immunotherapy, cabozantinib continues to have an important role, and will continue to have a role in the second-line therapy for our patients with metastatic renal cell carcinoma, and just gives us another definitive option for our patients in that situation.
Conclusion. Progression-free survival was longer with a cabozantinib than with a everolimus among patients with renal cell carcinoma that had progressed after VAFR targeted therapy. Thanks.